Good morning and welcome to our Community and Health Services Committee meeting for September the 10th. Today we'll be hearing from delegates on consumption and treatment services and discussing the paramedic services response. In addition, we will be considering a motion related to the consumption and treatment sites. I'd like to now call on Julie Hale, the committee clerk, to conduct a roll call.
Regional Chair Redmond.
Present.
Councillor Craig.
Present.
Councillor Deutschmann. Chair Erb.
Present.
Councillor Foxton.
Present.
Councillor Harris.
Present.
Councillor Hunick.
Present.
Councillor James.
Present.
Councillor Liggett.
Present.
Councillor McCabe. Present. Councillor Nowak. Councillor Salonen. Councillor Shantz.
Present.
Councillor Burbanovich. Councillor Williams.
Present.
And Councillor Wolf.
Present.
Thank you.
As we begin this meeting, we are again reminded that many of our homes and places of employment in Waterloo region are situated on the land that is the traditional territory of the Haudenosaunee, the Anishinaabe, and Chinootan peoples. We recognize and deeply appreciate the historic connection to Waterloo region, and we also recognize the contributions Indigenous peoples have made in shaping and strengthening this community. We are grateful for the opportunity to live and work here and reaffirm our collective commitment to keep the promise and the challenge of truth and reconciliation real and intentional in our region. Are there any conflicts of interest under the Municipal Conflict of Interest Act? None. We have no presentations. We have 3 delegations. However, they were told we were going to be getting at 9:45, so I think what we'll do is we'll move over to the consent agenda, which is item number 6 on your agenda. And if you wish to remove an item from the consent agenda, please indicate so now, as we will not take questions on consent items unless their items are requested to be removed to the regular agenda. Are there any item you wish to have removed from the consent agenda? Councillor Wolf.
Through you, Mr. Chair, I'd like to comment on the Immunization of School Pupils Act and School Compliance Report, which we have for information. Okay?
Go ahead.
All right. I just wanted to comment on the report, which I found very interesting. I would like to congratulate staff on the improvement in compliance rates during the 2023-2024 school year. The rates in Waterloo region reached or surpassed pre-pandemic levels. However, I was disappointed to see that once again, due to provincial funding restrictions over several years, the current provincial cost-sharing level is only 68%, and this represents a provincial funding shortfall of $2.5 million across all public health programs. Again, we are subsidizing provincial programs as the province falls short in its commitment to provincial immunization coverage. When speaking with MPPs in our region, this is something we should bring up to see if it can be remedied. Thank you.
Okay. And you're simply, you're not asking for a response from staff, simply expressing your concern.
Yes, I'm just expressing my concern and letting the public know again that we're put in a difficult position.
Thank you. No. Anyone else? Okay, thank you. So we don't need a motion on that because it was for information purposes. Yeah, I think we'll go back to delegations now. And so the first delegation we had who had registered is Simone Morrison. Are you here yet, Simone, in person or online? Okay, we'll wait. Nina Deeb. Nina, are you here? Okay, welcome, Nina. You have 3 minutes to speak. Welcome and come to the podium, please. And just a reminder for delegations that if you conduct yourself in any of the following manners, it will result in an immediate removal from the meeting of interrupting councillors, staff, or other delegations, derogatory statements about councillors, staff, or others, turning your camera on at inappropriate times, and hate speech or defamatory comments. And one other reminder, please don't take offense if following your presentation there are no questions from council. This is council's time to really listen and reflect upon the opinions and ideas shared with us from community members. Quick reminder to the members of the audience, you're asked to maintain order, and that means address the committee without the permission of the chair. Don't interrupt anyone. Disrupt the meeting with unreasonable noise or vocal expression such as applause, booing, or cheering, and displaying of any signs or posters. Nina, you're on.
Good morning. Good morning. My name is Nina D. I would like to speak.
I don't think your microphone is on. Yeah.
Good morning. My name is Nina Deeb. I would like to speak in favor of my council's continued funding and the region's continued operation of our existing safe consumption site. There are false statements being made, including by the Premier. He admits he's never visited a safe site, yet he did not hesitate to make a judgment. This was a one-person decision. This decision has serious implications for our community. I did visit this site on Saturday morning to understand what the site is. Although the site has no obvious benefit to me, it has compounding benefits to my community. This is visible to anyone paying attention. I walk this city and have not seen a discarded needle in several years. These sites do not distribute any drugs. The site is real estate. It is a place. It is a safe place. The Premier made a decision that would result in overdose deaths. It would increase the pressures on our first responders. It would increase our costs everywhere else. Our hospitals, police, paramedics, social workers, among others, without consultation, against evidence, without understanding, without knowledge of the matter that he was passing judgment on. This was a bad decision. We should always obey the law. When bad decisions are made that can result in preventable fatalities, the correct response is no. No. We know what is right for our community. We know this based on our data that we have been collecting. We know this based on the progress that we have already made. If the province is looking for partners with the municipalities, it should act as a partner and not make decisions for us. We are adults. We can make our own decisions, or at minimum, we can be at the table. The province can help by downloading tax revenues that is generated on real estate in our region. None of these funds are being reinvested in our community services. We need these funds to be reinvested in order to continue operating our social services within our community. If the province would like to assist, they can do this, and we welcome the assistance in the form of checks. They can make the checks payable to the region of Waterloo. Thank you, and I look forward to answering any questions if you have any.
Thanks, Nina. Are there any questions? Chair Redmond.
Thank you, Chair Erb. Thank you very much for coming in, and I'm sorry, I maybe should know this. What's your relationship? You've obviously taken a great interest in CTS and the announcement of the province. Can you just tell us what your connection is and where your concern comes from?
I'm a community member, and I'm involved with many levels of my governance. I've been to the region, I'm at my city, and I do delegate regularly at Queen's Park. I've been requesting funding for some of the shortfalls that we've been experiencing. Specifically, most of our shortfalls are coming from Bill 23, which was supposed to build more homes. We've been building fewer homes for 3 years in a row in Ontario. So that legislation has just led to shortfalls within my municipality, and now we're seeking money to continue operating the services that we already had, and these shortfalls were created. So my connection is, I'm connected many different ways, but I see this as an austerity measure on some of the individuals within my community that need the help the most. We can have these sites to bring people up out of the despair that they're in. We shouldn't be pushing people out or down. We should be helping people up. That's my connection.
And if I could, just one supplemental, because clearly you're familiar with the project. The Heart Hub, the province is telling us, is very much modeled on the London wraparound services. And I don't know if you've been to that establishment, but I haven't. They can quantify the money that they're saving paramedics, hospital staff, and police in providing these services. If you've been lobbying for more money, can you just talk about the investment? And I don't believe it's an either or, because in London they have a CTS in their hub model. There has been a long hue and outcry for more housing money, more rehab beds, and more support for mental health. And I'm just wondering if you can comment on those aspects of the Heart Hub, notwithstanding they're not saying there's a CTS there.
I'm not as familiar with that program as you are, but my request for funding is, for the most part, to keep up with our population growth, to be able to fund at least at the same level that we were already funding, and to maintain the services that we already had. That's what I've really been after. Is I'm not looking to have anything cut. I want to maintain what we already have, but we just don't have the funding based on the shortfalls that we've been experiencing, and that's where I see the shortfalls coming from. But I would be very happy to read more about that, to know more about that.
Thank you for coming in.
Thank you.
Councillor Deichmann.
Thank you, Chair Erb. Thank you very much for coming in, Ms. Deeb, and providing your comments. Can you speak to, or what are your thoughts on the importance of not only having treatment services available, but also continuing to maintain harm prevention services?
The prevention services are so important, because if we don't prevent we can prevent overdoses. When we prevent, when the overdoses occur in a controlled environment, it eliminates so many other services that would be required. And not only that, if the site isn't available, where will this occur? Like, we're not going to stop this from occurring. It's not reasonable to think that we can just remove the site and all of a sudden we're not going to have overdoses happening within our community. We've really just controlled it. We've brought it to an area, and from there we can move forward with not just prevention but treatment. There also, the other flip side of that is the treatment. When people are ready for treatment, that we have the available services there to be able to move into the next position, because until someone's ready for the treatment, it can't be forced. But we can try to we've made very good progress. It's visible to anybody walking around. I can wear open-toe shoes around my downtown again, and for many years I didn't, because I didn't know if I was going to be coming across a needle. And I really don't worry about that anymore. I haven't seen one in years. So from the perspective of somebody even walking your community, I see the benefits that are there. And I'm just a lay person out there walking the community, so I know what the response means when somebody was ODing. We were calling police, we were calling paramedics, the fire department would show up. It's a 911 call quite often, which brings everybody. So we are deploying all our services, all our response services, to something that we were responding to, like in isolation. Like, we were responding to it very well. We are responding to it very well from what I see. And the workers within the system are telling us, they're giving us the data, and the data is there. We just have to analyze it.
Just to follow up, Chair. Yeah, thank you I appreciate your observations, your anecdotal observations of what you're seeing, because we do see in news reports that crime where a CTS is located is reduced over time. But I just wanted to ask you, you talked about forced treatment, so if you could talk to us about what are your thoughts on voluntary versus involuntary treatment?
The treatment has to be voluntary. It's never going to work if it's not voluntary. There's always going to be relapse. If you look at addiction, the way addiction just takes over a person, they're going to relapse. And if they weren't willing to do it in the first place, you're just wasting resources. The person has to be willing and ready for the treatment.
Thanks, Nina, for your presentation.
I have a question, Chair.
Sorry.
No, it's fine. If I'm the last one on the list, can I go, Chair?
You
Okay,
are
good,
now.
go. All right, well, thank you for coming in. I recognize, the community is very passionate about this issue. I can recall, only a few years ago, it seemed like, I guess it was last term, when we had, this matter before our council on the location of a potential CTS site, and the public meetings that we had across the region and the community that came in and spoke to it, even those that were here last council meeting, obviously are very, again, passionate about and care for these folks that don't always have the ability to have their voice heard as strong as perhaps other matters. I was once a skeptic myself, frankly, of a CTS site, and I vividly recall the church minister coming in, talking about the people in the back corners of his property and the stairwells, the needles all over our downtown. And I would agree with you, frankly, that over the last few years we have had an immense, track record of, frankly, keeping those things, contained within the CTS site. And our CTS site is probably a shining example, frankly, of operations throughout the province. I've had people come up to me and say, the CTS site only serves about 50 people, a day. That doesn't seem like a lot of people. 18,000 roughly added up over the year. I mean, speak to perhaps these 50 people and the amount of potential services and, the potential for them to get help long-term that they needed that they wouldn't have had before. I think that's an important story that not a lot of people hear about. They just hear 50, and that's not enough. If I had 50 people coming to my business every day, I probably wouldn't be able to financially survive. But the 50 is a small number, but a big, important one. I don't know if you can speak to that quickly.
About the size of the number?
Well, just the 50 people that you serve, and how their lives have potentially turned around for the better. They've maybe found housing. They've found those wraparound services that they would normally never receive, right?
50 lives. So my response to that is every life matters. And I've known people that have gone through addictions, that have cleaned up their lives, and they're members of society, they have families, they're working, but it will tell you, like, they actually describe themselves as, they call themselves addicts. They don't say, like, they will say, like, I'm an addict, like, I as a recovering addict, they describe themselves usually, which means that they're very aware of the power of that addiction, that it can pull you back, but I don't have this experience, but I believe them when they tell me their experiences of how powerful it is and how much they fight to stay afloat sometimes. But the 50 is a big number. I think that's a very big number. I'm content that this is if this is helping 50 people. I heard that it was about 200. I think I read. That could be not accurate, but 50 is good for me. I'm happy that it's helping 50 people. That's fantastic.
Okay, I don't see any speakers. Thank you. So go back up to the top of the registered delegations is Simone Morrison. Are you here, Simone, in person? Oh, you are. Thank you. Welcome. You have 5 minutes.
Good morning. Thank you so much for having me today. My name is Simone, and I am a harm reduction worker. When I tell people what I do for a living, I often get the question, what's the hardest part of your job? I have the same answer every time. The absolute heartbreak and deep guttural anger that comes with having to explain that the folks we serve are deserving of basic human rights. I am a person who cares about people who use drugs, because as it turns out, that is most people. Cannabis, tobacco, alcohol, and caffeine are regulated and socially accepted. They don't typically leave us wondering if we will die each time we decide to take it. Due to the decades of the war on drugs and poor drug policy, this is not the case with illicit street drugs. With advocacy, data, and research, many harm reduction practices have been proven to help mitigate some of that risk. Consumption and treatment services, safer supply, and drug checking at their core are programs that provide life-saving health care. What we don't talk about enough is that they provide connection. Oftentimes to people whose survival has been criminalized and are intentionally excluded from our community. When we are faced with things that make us uncomfortable, like drug use, we want to distance ourselves from it. But what we know is that ignoring something does not make it go away. These programs are about providing connection and collective community care. It's about building people up so that they can show the community, and most importantly themselves, that they were always and always will be worthy. We talk about 50 people. I would like to highlight some of the folks here behind me. These are representative of some of that 50 to 200 people that we're talking about here today. Harm reduction programming provide people a safe place to be welcome to, where people know them by name, care about their well-being, and see them as their whole true self. That may not sound like a big deal, but it is something many of us take for granted. Despite all of the incredible work that has been built on the backs of those who have suffered the most during this crisis, and the evaluations proving that these programs are working, they are currently being forced to close. In spite of the ongoing public health emergency that is crushing residents and staff of local service providers, the region is still lacking a successful, coherent drug strategy. 820 lives from our region have been lost. 820 people who have meant something to someone. This is apparent at the last month's overdose events where hundreds were in attendance. When these services close, there will be an unprecedented number of deaths. People who use drugs and service providers truly cannot go back to a time where these doors were open. I fear for the community of care we have worked so hard to build. Please hear me today when I tell you that the bodies will pile up when these doors close. I recognize that these closures are a federal and provincial decision. However, municipalities are not powerless. Can you take a moment to reflect on the privileges that you all have and honestly say that you have exhausted every single option to keep our people alive? I urge Council to express to the province the community outrage at the defunding of the Sanguine Health Centre CTS site in Kitchener, reflective of the valued partnership that community members have heard so much about since the CTS was first established. I encourage Council to expedite a consumption service via the Federal Urgent Public Health Needs Site Exemption, also known as UPHNS, into the community before any threatened legislation is tabled in the fall. People's lives, access to basic health and social services, and the extreme burden on emergency staff and nonprofit staff matter. If 820 members of these community died in any other way, there would be immediate and swift changes. So I ask you to reflect. How do you feel and view people who use drugs? Do their lives matter to you? If you are lucky enough to not know somebody who has died by a drug poisoning, with these closures, that could change. So with that in mind, and my time coming to a close, I would like to extend an honest offer to train any council member sitting here today that doesn't currently know how to use naloxone. The reality is, you may find yourself being the one to respond to a drug poisoning as our community is about to become an unsupervised consumption site. Thank you for your time.
Thanks, Simone. We have a couple questions. If you would please stay there.
Yep.
Councillor Deutschmann.
Yeah, thank you, Ms. Morrison, for coming in. I just wanted to find out, how long have you been involved with the CTS?
So I don't actually work at the CTS site. I do work for Sanguine Health Centre, and I've been an employee for a little over 10 years now.
Okay, so I was just wondering if you were involved with the initial meetings of the community, et cetera, to establish the CTS?
I was.
Okay, so can you tell us about the work that went into establishing the CTS here in Kitchener?
Yeah, it's hard to put into words. A lot of work, a lot of dedication from so many people. I recall when we came here in front of you back many years ago, we had a person with lived experience come and share his story. And that alone, like having it be on the backs of people who are using drugs and are living this life every day, having them to be the ones at the forefront, I think there's not a lot of recognition for that. They are the ones that will have to save their friends when CTS closes. We talk a lot about first responders and the trauma that comes with that, but we don't talk enough about the people who live this life every day and how that sits on their shoulders and they don't get recognition for that. It's been years and years of really hard work, and quite frankly, I don't know how, as a community, we're going to go back. It feels like we're starting from the beginning again.
Thank you. Just a follow-up, Chair. Thank you. The HART model does not allow for safe consumption. It's not included in that. In fact, I hosted a town hall on homelessness this year, and we had the people from London that operated their hub model. And it was in that context that the hub model was discussed on homelessness. And so it's our understanding that the province is looking to that. You mentioned the UPHNS, and I don't know if you're aware, the provincial government is going to specifically include that as something that we can't do in there. Can you talk to us about the lack of any consumption services, safe consumption services, and in addition to that, the safe supply, the testing of drugs, all of that, what we can expect as a community, given that you've had X number of overdoses, but I suspect it'll increase considerably if we can't do all those other things. So if you could talk about that.
Yeah, I think it's important to note that the CTS site, that is its main function, right, to reverse overdose deaths. And they do it incredibly well. However, it serves as so many other things than just that, right? It's what brings people through the door. When you have people who have been ostracized from their community, they don't feel comfortable accessing traditional health care. And so, yes, offering the overdose response is a really big draw, but it brings them into a community of care to match so many of their other needs, right? Why do people have so many healthcare needs that are not being met? This is the type of site that brings people in. You have trained professionals who have lived and living experience. This is a really important core of all of the services that we have, is that we include people who use drugs. And that's on a spectrum, right? That's people who maybe are abstinent from substances now, but some that are also not, and that's okay. That's how we're going to get people to come in, because we know they're not walking through other doors. Not having that at its core in some of these services like Heart Hub funding is a huge problem. You cannot help somebody who is just trying to survive every day and not die, or people who are dying. How do we help somebody when they're dead, right? There's nowhere to move from there. There's lots of data and research to prove that the things that we're doing from a harm reduction lens are working. Like I said, there's lots of folks behind me that work in this community that are a part of the services. They would not be a part of all of these things. They would not be employed. They would not be doing all of these things if it wasn't for services like this that bring them into that care. So it's a huge problem. It's a huge, huge problem. We are going to have many deaths.
Chair Redden.
Simone, thank you so much for coming in, and know that everybody around this horse show values what you and the people in the audience are doing. As a service manager and public health board, we see the significant impact, and we couldn't provide the services that we do without our partners. I think back 2 councils ago to 2014 when a busload of councillors went down to South Riverdale, and my take home coming back from that CTS was actually the trusted relationships with the people that were there providing service, and that's really what allowed people to find a better way in their life. The Heart Hub, I think, is a yes and. I don't think it's an either or, and Councillor Deutschman's already pointed out that this this provincial government's been very directive in some of these decisions. I just want everybody here to know that there isn't an opportunity that goes by that all of us, and I talk to ministers monthly at the provincial government, talk to the health minister, talk to other ministers in different portfolios to say how very, very important the harm reduction is, in addition to the services that are being provided through Heart Hub. I think Heart Hub is a great model, but to me it's not an either or, it's a yes then and. So I guess it's just to say thank you very much, because what you do is very important and really difficult work.
Thank you.
Councillor Shantz.
Thank you. Thank you for coming today and for presenting. And I recognize that addictions are such a very complex issue. my question is, in my mind, I'm trying to understand between the CTS and the HART model, and I agree with Chair Redmond, I think it's both and. But what is missing currently in the CTS site in terms of wraparound services that would be beneficial? Because I know we have some.
So what, sorry, your question is what is missing?
In the current CTS model, what kind of wraparound services would you add to that if you could?
I think for me personally, I guess I share a little bit of a different sentiment. I don't think it is, I don't think that the HART model is going to provide enough, so that's first and foremost. Secondly, I think that one of the biggest things is I don't particularly work at CTS, so I just want to really put that out there that I'm not in there every single day. I'm kind of like in a peripheral sense. I'm around, but I know that we need more staff, right? More people to do the work. We don't take good enough care of the people that are doing the work, especially the folks with living or lived experience. For those folks, who are experiencing homelessness, who are living in a tent and come to work every day to do their job, that is extremely difficult. I have a hard time getting out of my home, and I have all of the amenities, right? So taking better care of the people doing the work is kind of like one of my answers. I think, yeah, I know that the site is always open to having more partners. I don't have any specifics about what that would be. Again, I don't work specifically at the site, but I know the more the better. The more people that want to get involved, I think that they would be very open to that.
Councillor James.
Thank you, through you, Chair Erb. I'm just wondering if we can actually pull Councillor Deutschman's motion ahead of the agenda once the delegation, so we can address this all at once and speak and vote to that.
You have no question to the delegation?
No, that's why I'm queuing in last.
Okay. We do have another delegation. I guess I would be in committee's hands on that if we do that. We have a fair number of people here waiting for that notice of motion. But first of all, we'll go to the next delegation.
Thank you.
Thanks for appearing. Councillor Craig.
Sorry, Mr. Chair, I just got in late. Just one quick question. People who are addicted to drugs.
Is this question to Simone, our delegation?
To the delegation.
Okay. Do you want to come back up, Simone, please?
I'm a little slow on the thing.
Not too far.
People who are addicted to drugs, how often a day do they take drugs?
I mean, multiple.
It's a general question.
Yeah, multiple.
I know you can't be specific.
Multiple times a day. For a lot of folks with opioids in particular, they can start experiencing withdrawal symptoms anywhere from an hour to a couple of hours in between usage.
So they would, in fact, take drugs more during the day once they leave the CTS site?
Folks are able to use the site multiple times in a day.
I'm sorry?
Folks are able to access the site as many times as they would need in a day, yeah.
Okay. Thank you, Mr. Chair.
Thank you.
Our next delegation is Councillor Stephanie Stretch, representing Ward 10 in the City of Kitchener. And Stephanie, you have 3 minutes.
Good morning, Council and Chair. You did my intro for me, but I'm here as the Ward 10 City Councillor for the City of Kitchener. I'm here to offer my support for the CTS site. That resides in Ward 10, about a block away from my home, where I live with small children and my in-laws as well. This issue also is very personal. I had a brother die of a drug overdose a few years ago. And I can say qualitatively, in my experience, it helps keep the neighborhood clean and safe. And the staff, security, and participants have all helped keep our gardens, yards, and porches clear from paraphernalia. Just like the first delegate said, it is a noticeable difference in the localized neighborhood. It has helped quite a bit. I can take the kids to the park now in bare feet if they want to go. And you might be wondering, why does it happen? It happens with kids. They lose a shoe, something happens. And so it definitely has made a cleaner, safer experience. I'd like to add that it's not perfect, but it definitely helps. And I'm here for any questions too.
Thank you. Councillor Deutschman.
Thank you, Chair. Councillor Stretch, thank you for coming in today, and I appreciate you coming because you have your experiences frontline being there. First of all, condolences for the loss of your brother. Very sad. I just wanted to touch on, prior to, just quickly, were you involved in any of the community discussions when the CTS was being planned, et cetera?
Yeah, I was there just as a
Sure.
resident.
Okay. And at the time, there were what were identified as red zones, areas with significant overdose occurring. Downtown Kitchener was one, and the other was downtown Galt. Unfortunately, we were never able to get something set up in Galt. But just, again, just if you could tell us what your experiences were like pre-CTS, when that was an identified red zone, and after the CTS was established in your area.
So pre-CTS, there was definitely fear in the neighborhood that, it would worsen and that we would have an attraction of a whole bunch of, drug addicts that were like zombies. There was so much fear. And because we were also seeing a lot of needles, I remember walking by Center in the Square, and my daughter was 2 at the time, and she picked up a pipe. And I was like, okay, set that down. Since the CTS has gone in, I have seen some paraphernalia around, but it's nowhere close to the way it was. The corners of the backyard, spaces on your porches where you can't see, they definitely are safer because we do have more of a presence of staff support. Participants also feel a sense of pride and want the community to host the site, so that often it's all hands on deck in the neighborhood from the service provider helping keeping it safe and clean.
Yeah, just a follow-up, Chair. Thank you. We hear from academics who study this, providing us with evidence that crime is reduced in areas where the CTS is established. We hear from police similar sentiment with respect to that issue. So I'm just wondering, from your experience, if you can you comment on your observations about the level of crime pre and post CTS?
Mm-hmm. So I don't think all crime, is placed on the back of people accessing the CTS site. I can't say I've noticed a significant difference quantitatively in the neighborhood. Remember where this is also close to an encampment, close to a lot of social services that people are accessing. So I can't say I notice a huge difference in the amount of neighborhood crime happening, but I can say that the staff and the CTS site are a resource in, asking for help or needing help.
Okay, thank you.
Sorry, Councillor Paramedic.
Thanks, Chair Erb, and thanks, Councillor Stretch, for coming in and sharing your perspectives as the ward councillor. I think it's fair to say that at the city we hear from people on both sides of the issue, but my personal sense in terms of the majority of people I hear from and from what I'm sensing from you is that while there may be some people who don't share the view that you expressed, my view is that the vast majority in the area do in fact find things are better. Would you concur, now that you're the ward councillor, that that's what you're hearing from people as well?
Yeah, exactly. Not everyone, but generally, yes.
Yeah, and I think that's an important thing to remember, because that, I think, has been our experience in terms of the overall usage of the facility. And I think I'll leave the rest of it to comments later on. So thank you for coming in.
I see there are no other questions. Thank you for delegating. Picking up on Councillor James' suggestion to bring Councillor Deutschman's motion forward, because of all the delegations that are here today are speaking only to this issue, and if committee is agreeable, then we'll move ahead with that. I see heads nodding all in the same direction. Councillor Deutschman, do you want to speak to your motion?
Thank you, Chair. I'll move it, but is there I don't know if you have a seconder. Chantel.
Seconded by Councillor Wolf.
Okay, that's fine. I think I've had some discussions also on this motion. There was a suggestion of an amendment to be made to the motion, and it's with respect to the issue of the UPHNS. Let me just, one second. They don't. I was speaking with somebody about it. Just one moment. My apologies, just 1 second. I'll forward this to Regional Clerk. Okay.
Are you forwarding an amendment to the clerk? Is that what's happening? So this is an amendment to your motion? It's an addition. Okay.
Just another line.
Yeah, another immediate result regarding the UPHNS.
Okay, so you have the floor.
I'll just read it for Councillor Hennick.
Yes.
Okay, so the addition is to say, and be it further resolved that the Ontario government does not take steps to pass legislation that would prohibit the establishment of temporary urgent public health needs sites, UPHNS, which is one of the proposals of the provincial government. That is a federal request, and we have several of them in our community, but the Ontario government is looking to target those as well.
Okay. So procedurally, we don't need anything to add this to the motion, I don't think, do we? In the seconder, you're in agreement with that? Yes. Thank you. Okay. Councillor Craig?
Well, Mr. Chair, there's also the issue here about, in Councillor Deutschman's motion, which I support, regarding the heart hubs. And I'd like it to be understood, or do I have to have an amendment that we would suggest that there would be 2 in the region, one in Kitchener and one in Cambridge? Okay? That's important.
Yeah, I noted previously that Councillor Craig had mentioned that in previous correspondence or what have you. And I thought about that, and I thought it might be something, Councillor Craig, that you may wish to consider as, and if Council agrees, as a direction to staff to look at the opportunity to create a site in Cambridge as well as in Kitchener.
As long as it's on the discussion table, I don't mind.
Perhaps Dr. Wong could speak to that.
Yeah, a heart hub application would need to be led by a community healthcare provider. But what we understand from, what we see from our data as well as conversations with community providers is that they want to take advantage of the opportunity that's presented to communities that have to stop their CTS functions to apply for a hub model that not only provides services where it's needed in Kitchener, but also has a satellite in Cambridge. So that is where, staff and community partners that's what they are looking at, and that's where I anticipate we'll be putting forth our efforts. Because we've been told we can apply for a heart hub model, so A makes me think that it's one, but we've also been told that we can apply for a satellite as part of the heart hub as well. So that satellite, it would make sense for that satellite to be in Cambridge.
Okay, and the intention would be to apply for the satellite as well?
Yes. Okay. That's where the conversations are at this time.
So just, do you want to speak to your, to the motion first, and then we have a number of councillors that want, okay, so go ahead.
Thank you, Chair Erb. Like many, I was very surprised when I first heard the news that the Premier intended to shut down 10 CTS in the province. And I'll acknowledge that I am angry about this decision. These are facilities like the Kitchener CTS that have been developed through extensive review, preparation, collaboration, leading to successful implementation. The Kitchener site has been operating effectively for several years. The question for some is, how do you measure that success? For advocates who work in the field of drug addiction every day, they consider the Kitchener CTS to be successful. The CTS has saved many lives, reversed overdoses, has provided those with drug addictions a safe place to inject, and when ready, a pathway to treatment. The CTS is a pathway to treatment, voluntary treatment, when an addict is ready to accept treatment. And I'll note comments from Ms. Cobb-Fleisch, Julie Cobb-Fleisch, Director of Communications, I think at Sanguine. Thank you. CTS sites offer a range of vital services, including supervised consumption, overdose prevention, harm reduction, supply distribution, naloxone kit distribution, wound care, sharps disposal, and access to mental health supports, addiction services, primary care, and social services. She added, employees at the site have long recognized and prioritized the importance of safety for all community members while balancing the need for the life-saving services. And police data shows that several types of crime and delinquency have decreased in downtown Kitchener since the CTS opened. It's well known that involuntary treatment for drug addiction is not successful. This was noted in the document recently published by AMO, the opioid crisis. Research shows that voluntary treatment consistently outperforms involuntary treatment. The report notes that involuntary treatment has limited benefits, high costs, and legal and ethical issues. And the report notes that, quote, a complex challenge like the opioid crisis cannot be solved by simple, short-term, standalone solutions. To meaningfully address this crisis, action is needed across a whole continuum of interventions, including investments in prevention, treatment, and enforcement justice systems, and harm reduction. These actions are inherently connected and supportive of one another. And this is exactly what this motion is asking. Continue to invest in the HEART model, but continue to invest in harm reduction, which is the pathway to treatment and has demonstrated a high level of success in our community. And for those that want to consider an economic argument, the AMO report noted a Calgary study that found $1,600 in savings is generated for every overdose managed at a supervised consumption site. The Kitchener CTS has reversed 1,031 overdoses. At $1,600 per reversal, that's a $1.65 million savings to our community. If you close the CTS, you shift provincial funding to the municipal tax base, and you can expect the number of overdoses to be even greater without access to all of the services provided by the CTS. An overdose outside of a CTS will, if discovered, result in a response from police, fire, paramedics. Thanks for being here today. I know we're dealing with your report later on. And if the victim has to be brought to an emergency room, then you risk offload delays. In a media release issued by the Registered Nurses Association of Ontario, they said the planned closure of the sites could lead to overwhelmed emergency services and a spike in healthcare costs. They also claim it will result in increased deaths from the toxic drug supply and the spread of disease from unsafe needle sharing. Supervised consumption sites save lives and provide evidence-based, life-saving services and comprehensive mental health support. You can't help a dead person. For those that would suggest that these motions are meaningless, I want to share a recent email that I received. I've been in contact with Dane Kent, a CTS manager at Regent Park Community Health Centres in Toronto. Dane contacted me last week to discuss this motion, which came to his attention through social media. He's working to try and save their CTS, and he's hoping to have Toronto pass a similar motion. Dane sent an email yesterday to a group, which included me. Dane noted the following. To update this group, Toronto Board of Health unanimously passed a motion during today's meeting to amend the 2025 budget to provide funding for their injection site. They will no longer be reliant on the provincial government for money now. We can thank Rob for helping to nudge us in the right direction with his notice of motion and providing me with some background information during our conversation on Friday. One never knows what the impact of our advocacy will be. We should never diminish our advocacy, never devolve to cynicism, but consider that we have a powerful platform and we can send a strong message that will ripple out and have an impact in ways we are not aware of, but can be powerful and transformative. We should never lose sight of that. I ask for council's support for my motion so that we can send out a powerful message to be shared with other communities where CTS, threatened with closure, is currently operating. Thank you, Mr. Chair.
Okay, Councillor Hune next.
Thank you, Chair Erb. The most important feature of the CTS sites is the life-saving measures. However, Councillor Deutschmann also alluded to many cost savings in policing and in paramedics. And I know that this has been quantified in the City of London. So I'm wondering from Dr. Wong, how would we go about measuring the cost savings for Waterloo Region if we maintain operations at the CTS site?
Thank you for the question, Councillor Hunick. I think it would be, I don't think it would be possible at this time to quantify because the landscape will be shifting in that there will be the CTS that will close, but there will also be heart hub services that will start to be brought online. So I do think that, you know, if the situation were that the CTS would close and that would be it, then yes, you would definitely see more increased calls to paramedic services because you would have many overdoses that would not be reversed by the CTS. But I think right now it's not possible to, you know, estimate the cost savings because we don't know the impacts of both the closure of the CTS and the increase in service in other areas besides harm reduction that the Heart Hub model would also bring to the community.
A follow-up, Chair Erb, if I may. If council, in partnership with the community, finds a way to keep the CTS open, is there a way that we can put plans in place to measure this going forward?
For sure, we would continue to monitor the data from our paramedic services, which would show whether there were increased calls in certain areas. The other thing I wanted to point out is that the legislation the government is intending to put forward for the closure of some of the CTS sites includes a non-government funded CTS site in Toronto, I believe. So it's not just the funding, they intend to have these sites close, whether or not they're funded by the provincial government. Thanks.
Councillor James.
Thanks. Through you, Chair Erb. I like many, was very disappointed by the province's announcement at the AMO conference a few weeks ago, and was receiving calls from community and emails right away with just the shock with having no notice around this. Before I get to my question, I just have a few things in so quantifying some things here, because I think there's a lot of misinformation about CTS in the community and the impact that the CTS and the support systems do have. So it is a vital healthcare service where individuals use their own drugs under medical supervision, preventing overdose and connecting them to essential supports like mental health services, addiction services, housing. In 2024, the CTS facilitated 25 referrals for services like addictions counseling, community treatment, methadone, rapid access addiction, medicine clinic, detox, and residential treatment. 11 more referrals were made to mental health supports and 69 referrals to primary care. In the first half of 2024, they also helped to bridge 146 connections to social services like employment and housing. The CTS also employs a number of individuals who would otherwise have difficulty finding employment due to criminal records, housing, and other complex health issues. Many of those individuals are already expressing distress about what will happen to them beyond March of 2025 when the CTS closes. At the CTS, they offer more than just supervised consumption. Primary care interventions like vaccines, wound care, testing for infectious diseases like HIV and hepatitis C are also provided. These services are critical in protecting health of both individuals and the broader community. Since 2019, the CTS has seen over 53,000 clients and visits and reversed over 1,031 overdoses without a single death. The work has saved lives and provides a gateway to recovery for many. The closure of the CTS sites and the cancellation of funding of other harm reduction services will inevitably place, as we've heard, burden on paramedics, our policing, hospitals, services that are already under an immense amount of constraint. We've heard this today. It will also increase the strain on pushing individuals back into the streets and into emergency rooms. And there are misconceptions, and as we know, despite those, this does not encourage drug use. Based on some of the data I collected, there were calls to the Kitchener CTS. There were no police calls to the Kitchener CTS since February of 2024. The only 2 security incidents on the perimeter in July. So we continue to face an opioid crisis. I do believe that closing these will, impact our community in greater negative ways. And I know there are community members who, support the closure for their own reasons. But I do believe that none of us are immune to, having people in our lives that have maybe been an addict, or people who have overcome and are still trying to navigate. And one of the things I do want to say, because I do believe that lived experience is very instrumental besides all the data, and I do want to just read this. And this is from somebody who has benefited from the CTS site. I am an addict. And I have been an addict for most of my life because the drugs, I have lost everything and everyone who has ever loved me. I've stolen and lied and been to jail. I did not finish high school. I did not have custody. I do not have custody of my child, and my mother has been raising her even though she is supposed to be finished raising children now. You think it is a waste of time and money to keep me alive, and so do a lot of other people. But people at the CTS love me. I am learning how to love me too. I do not want to die. Please don't close the CTS in Kitchener. Please don't. So I will end there. And Chantel asked my question just about the measurements and finances, so I know we'll get back. I do actually, Dr. Wang, in this announcement from the government, has there been any conversations regarding heart in that model? Have you or staff and the team been part of that at all?
No, we only heard when Minister Jones announced it at the AMO conference.
Perfect. Thank you very much.
Councillor Wolf.
Through you, Mr. Chair. I strongly support this motion and feel honored to second it. I think it's important that Council lets those who use the CTS and support it know that we believe it is a valuable part of our drug strategy. Harm reduction is important for many reasons. Many you've already heard. The obvious one is that it saves lives. Over 1,000 overdoses were reversed, but overdoses were not the only way the CTS was instrumental in saving lives. Our drug checking machine was used to put out notices to the entire community when there was a bad batch of fentanyl or other drug detected. This information saved many people from drug poisoning. The needle exchange program, which has been operating for decades, has prevented hepatitis C and AIDS from being spread by people injecting drugs. We also note that we are not only closing 10 CTS sites across the province, we are closing any CTS sites which operate in shelters that may also come under the new criteria. We are also closing the door for future CTS sites, like one in Cambridge. When Premier Ford asked for studies of existing CTS sites in Toronto, those studies indicated the CTS sites should stay and even expand. Not liking this result, he went to the court of public opinion. As Michael Parkinson has pointed out, public opinion should not dictate health matters. For health matters, we need doctors, experts, and scientific evidence. Those experts are telling us that CTS sites and voluntary rehabilitation and treatment are essential. I welcome, as do all among Council, the idea that the province is now going to put money into treatment beds and programs. We have been asking for this all along. Unfortunately, 378 beds for all of Ontario is only a drop in the bucket. Our drug strategy was based on 4 pillars, harm reduction being the first one of them, treatment, prevention, and enforcement, the other 3. We need all the pieces to fix this puzzle. Never has anyone said that harm reduction or a CTS location on its own would solve the widespread and complex problem. This provincial government has walked back many policies when they found they may be harmful to the community or there was an undesired effect to them. The Kitchener CTS location has had no increase in the crime rate, according to the police, less use of emergency services, and according to the daycare center in the vicinity, no problems there. The Kitchener staff have built up trust between clients and have built up trust between clients and staff, which has led to treatment. Closing spaces where people can safely consume substance will lead to greater public use of substances and greater use of emergency services. It is the role of government to protect human rights and the most vulnerable. Access to life-saving services should not be political. Sanguine, in their open letter to the province, puts it well. We urge the province to reconsider closing CTS locations in favor of a comprehensive approach which includes both harm reduction and access to treatment, ensuring care for all individuals, including those not yet ready for treatment." Unquote. I urge Council to show respect for the work done by the staff at the Kitchener CTS and the stigmatization of people with a substance abuse problem and embrace a solution that leaves no one behind. Thank you.
Chair Redmond.
Thank you, Chair Erb. I have no problem supporting this motion. And one of the reasons is because it's a yes and I don't want us to get into the dynamic of we have to save the CTS when there is a hub model that does offer some additional support. So Dr. Wong, I'm wondering for everybody here, can you just remind us, and it's sort of a 3-parter, so if I have to repeat it, I will, but the role of both the federal and the provincial government in the CTS and in CTS that operate in shelters, as well as the timelines for getting our ducks in a row for the hub model and the initiatives that have been undertaken by the region to provide leadership with our partners, because clearly we cannot provide these services without our valued community partners.
Okay, I'll try to take those one at a time. CTS, consumption and treatment services, are a model in Ontario that is equivalent to what is known across the country as supervised consumption services. So what is particular about the Ontario model is that the provincial government at the time, when it approved our site, it wanted to ensure that in addition to supervised consumption and other harm reduction type supports, that these sites would also provide referral pathways to other services like treatment. That's why the term treatment is in the title. So these sites, an agency, or in the case of the Kitchener site, it was Sanguine Health and Region of Waterloo Public Health, who together applied for an exemption from the federal government, because that's the only government that can provide exemptions for the existence of CTS or SCS, supervised consumption, as it's known elsewhere in the country, or UPHNS, urgent public health needs sites. So we have to first apply to the federal government for the exemption. Assuming they provide the exemption, then in the case of the CTS in Ontario, it's the provincial government that then considers whether or not to fund it. In the case, that's for consumption and treatment services sites, which are, meant to be services that are established on an ongoing basis. In terms of urgent public health needs sites, these are, again, something that an agency or agencies can apply for in order to be able to operate from the federal government. But these are not funded, and they're meant to be temporary. In the place of, but temporary on the path towards, getting a supervised consumption or a CTS up. So those, the government is indicated to staff that it does intend to include, to prohibit the establishment of additional CTS, as well as other sites similar to CTS, like urgent public health needs sites, as part of their legislation this fall that will close some of the CTS sites, including ours. While there is a technical legal pathway to ask for an exemption, there is pending legislation that will make those sites, as Councillor Deutschman pointed out, not possible to have in Ontario. That's kind of, that answers part of your questions about the two-layered approval process, so to speak, for sites of this nature. Sorry, you have to remind me your other questions.
The timelines to get up and running with the hub model, as well as the initiatives we've taken with our partners.
Oh, thank you very much. So yes, so for sure, what the government has indicated to us is that we have very short timelines for the application of a HEART hub model in Waterloo region to replace our CTS, a model that can include a satellite in another place like Cambridge. The deadlines for our lead agency to submit their interest is next Friday, September 20th. And by October the 18th, the full application with all the criteria that the government is asking for, which is laid out in its application document, has to be in. So these are extremely tight timelines. So since the announcement, staff have been working very hard. And when I say staff, it's not only public health staff, it's also community services staff, Peter and his staff, of working very hard, along with Sanguine, who is the co-operator of the CTS in Kitchener, to bring partners together to make sure that we can put in an application that meets all the government's criteria and that can optimize the amount of funding that we can get from the government. So these are extremely tight timelines. We're working around the clock on this. We've already had a first meeting with a large group of partners. We're having another one this Thursday. So there's a lot of work in order to be able to put together a Heart Hub application for the region, which would likely, as I mentioned earlier, be one that can focus on the areas of highest risk in our region. Where the CTS or in that area, as well as a satellite in Cambridge is what we're currently looking at. So all that to say that we're having to move very quickly, and so we're wanting to make sure that we put in the best possible application in order to get obviously to meet our local needs, but also maximize our chances to get the most funding that we can for Heart Hub in our community.
And just one final question. Is it correct to say that because we no longer are able to operate a CTS, we actually get at the front of the line in order to have our application for a hub model approved?
Yes, absolutely. So those current CTS sites which have to close will be given priority consideration for their Heart Hub applications.
Thank you.
Councilor Van Beck.
Thank you very much, Chair Urban. I have a couple questions to ask of Dr. Wong as well, and then I'll make my comment, if I may. And just to follow up to Chair Redmond's questions, Dr. Wong, in addition to priority, I believe there's also a multiple factor in terms of access of funding that we're eligible for as well. Is that correct?
The government has stated publicly when they announced, these new Heart Hub models that, a community could get up to 3 times the amount of funding that they currently receive for a CTS for a new Heart Hub model. So that's all we have as information at this time. I don't know if that answers your question.
No, it does. Thank you.
Okay.
I just wanted that clarity. And then the other question I have, and it sort of builds on something you touched on already and comments that Councillor Deutschman made. But in terms of the existing CTS site, we know there's well over 1,000 overdoses that have been handled. They've been handled, to my understanding, in the vast majority of cases by the healthcare professionals that work there. So it hasn't required, a tiered response from EMS, fire, police, and so on, but in fact was handled by the professionals there. So is it, in fact, because I think it's important to hear your professional opinion on that from, as the medical officer of health, would it in fact be accurate to say that in the absence of a CTS and those overdoses happening elsewhere in the community, that we can expect higher call volumes to those other emergency services that will obviously cost the community dollars and potentially impact response times for other residents as those pressures are there?
Yes. So, considering that the vast majority of overdoses that occur at the CTS site are reversed by staff at the CTS, I expect that there will be, a significant increase in calls to first responder services, including paramedics, police, if that service were no longer to be there.
Okay, thank you for that. And so, Mr. Chair, if I can just comment then now, I will be supporting Councillor Deutschman's motion wholeheartedly and thank him for bringing it forward. I too was disappointed by the decision to see the CTS sites be required to be closed. I can tell you that in terms of the heart hubs, this is that type of model that would focus on treatment and rehabilitation is something that Ontario's big city mayors have been calling for investment in for some time, and we know that needs to be part of the path to the overall solution. But part of that path also needs to continue to be harm reduction. I know there are some folks in the community that struggle with that, but the reality is CTSs save lives. And these people are somebody's son, daughter, mother, father, brother, sister, aunt, uncle. And we know that in all these instances where lives have been saved, it leads to an opportunity for folks to get to a path to treatment, rehabilitation, and having a healthier lifestyle in the future. I will say that, one of the difficulties here is that there are some municipalities where the municipality has not had the same experience with their CTS sites. And so the one part, and I will support the motion as it is, but the one part where I struggle a little bit with the motion is that it doesn't just focus on Waterloo Region, but on all of Ontario. Because I do know that some of my municipal colleagues in some other cities have not had the same experience that we've had with Sanguine, and I want to acknowledge Sanguine and the team for the great job that they have been doing. I can tell you, as the municipality that's the host to this CTS site, we have had little to no problems with the CTS site. Quite frankly, we have greater issues with some of the other social services that exist, whether it's the shelters or some of the other social services that exist in the municipality. That's not news to anybody in this room. The CTS has not been part of that problem. In fact, as Councillor Stretch indicated, in many instances, we've actually seen improvements in the downtown area, including needle pickup and cleanup and people not overdosing in public areas and obviously, and most importantly, the positive healthcare impacts. So I will support the motion. I want to reiterate Chair Redmond's comments. We welcome the heart hubs as part of the path and part of the solution going forward, but there will be a transition regardless. And I think this is certainly moving too much and too quickly, and we need to see both components to go forward and continue to make a difference in the lives of individuals. Thank you.
Councillor Shant.
Thank you. I have to find my voice now. I've been sitting for a bit. Thanks for bringing this motion forward, Councillor Deutschmann. I think it's an important issue and one that we need to obviously deal with. And my colleagues have expressed a lot of the information that's out there, and I'll try not to be too repetitive here, but I would start with a question and then maybe make some comments if I could. And it's a question that I asked to the delegation, and I'll ask it to Dr. Wong. And maybe I'll frame it a little differently. The Heart Hub model and the CTS model, if you could, because we have already articulated the importance of both of those, if you could bring those two together, in an ideal world, what would that look like?
The ideal model would be a heart hub model that would allow harm reduction supports, because it does look at treatment, it does look at housing, which are great things, right? Which we need, and this council has advocated for more funding for. But the missing piece is that the heart hub model prohibits harm reduction, with the exception of providing the lock zone. So we ideally would have a model where we have access to heart hub funding, but these heart hubs can also include the important component of harm reduction within the model, in addition to treatment, prevention, et cetera.
So you said something in there, excuse me, with the exception of naloxone.
Yes.
So can you drill down on that?
So the government has made it clear that services like supervised consumption, safe supply, needle exchange will not be permitted as part of the Heart Hub model.
Okay, thanks. I guess what two things. First of all, I want to preface this by saying the most important piece is the people. And but in saying that, I want to talk about the dollars for a minute. And that is, we can't keep working in silos. We're going to hear from our paramedics shortly about shortfalls there and how they all work together. And I'm just very frustrated that we keep siloing everything and we don't look at the big picture. We need to start at the ground and, you know, work with the issues on the ground. And part of that is the model I think that you just described, Dr. Wong, so that we can reduce paramedic services, we can reduce the police services that need to respond, and we need to start looking this in totality at the provincial level for funding. And so I find that very, very frustrating and an ongoing frustration for me. And I think that probably most of all my other notes have been already said, so I'll just leave it there. Thanks.
If I may quickly add, what I don't want to see, you asked me about what I'd like to see. What I don't want to see is the government, you know, saying, well, this is the pot of money that you can have access to. You can either have one or the other. Ideally, and so I wouldn't want the fact that we have consumption and treatment services, if we want to keep that, to be a hindrance to us getting maximum funding for our Heart Hub model. So ideally, it would be the Heart Hub model, including harm reduction services. So that you know, that doesn't then pit conceptually consumption treatment services site against a Heart Hub model. It would integrate the two. Thank you.
Yeah, I agree with you 100% on that. Where I was going was, what about the reduction in paramedic costs, the reduction in police service costs, the reduction in hospital stays? All of those pieces need to figure into the bigger picture. The funding for both is key to reducing some of those other costs. And I think we have to start recognizing that at the provincial level, really.
Absolutely, an integrated model is much more efficient. Thank you.
Moving along here, Councillor Craig.
Well, thank you, Mr. Chair. Just very quickly, what I'd like to say is I agree with virtually a lot of things that my colleagues are saying. Councillor Deutschman, Councillor Wolf, Councillor James have very sincere comments about what they believe. And I think it's important to understand that politicians don't lead public opinion, they follow it. And I think that's why Premier Ford has in fact come down with this edict that we're going to shut down CTS sites. And I think that's exactly what's happened. My concern all along has been outside the CTS site. And I've brought that up on a number of occasions about what's happening throughout the regional community. I asked for the health report to be updated, and there wasn't a lot of enthusiasm when I put it on the table, but it did get passed. I also suggested that we needed to have a more definitive statement for the province in terms of treatment beds about what we needed in this region, because of the large number of people that were under addiction. And that was before the announcement came down to shut down the CTS sites. So I want to make that point. So we all have a sincere belief, but I think we all have to respect each other with those beliefs too. I think one of the important things to remember here, and Councillor Harris brought it up, that 50 people at the CTS site were being seen daily. But my concern was outside the CTS site, in the community, where approximately, going back to the 2018 report, we had 2,000 people every day injecting drugs, and obviously multiple times. And there's a great cost to that, because there's a great cost to the ambulance service over the last 6 years that has transported over 8,000 individuals with opiate-related overdoses. So that's a huge cost. And I think we have to keep that perspective. So we can talk about the CTS site and what it's done. Fair enough, but I think we have to look beyond that. And I think also, what needs to be looked at is the fact that in my opinion, and it's strictly my opinion, that this isn't going to go away in terms of addiction issues with regards to the flood of illegal drugs coming into the country, into the region, and we're going to be living with this for a long time. And I think it's very important, and I've tried to stress this, that we need to look upstream, and we need to look at younger generations and how we're going to stop them from getting involved with drugs. And I think that's a really important issue that we have to deal with. Now, the motion today, I think, and we get back to the province and municipalities. I mean, we are, and we know this from experience over the years, that we're fairly powerless when it comes to dealing with the province of Ontario. They can make these kind of edicts, come down, shut things down, and they don't consult with us ahead of time. And that's happened before, and it's not unusual in terms of their behavior. And I think it's unfortunate, because I think it's hurt a lot of people that have beliefs and CTS sites and work in them. And I totally agree with that outrage, that in fact, it's terrible what's happened. But I think, again, I come back to the regional community and all the people that are using drugs outside the CTS site. And that's all I've ever tried to say to council. You need to start looking at that. I've brought this up a couple of times at the regional table, about 100 people dying last year, 100 people dying the year before. And if that was happening at roundabouts or crosswalks, you'd be outraged. But there is, and no one has said anything about that when I brought that up. So here we are today. I can't support Councillor Deutschman's motion for personal reasons and for the fact that it restricts us in terms of looking outside, because we haven't done a very good job on that. So thank you, Mr. Chair.
Councillor Williams.
Thank you, through you, Chair. Most of my questions have been answered. It's been a very thorough discussion. So I'm happy to support the motion, but I just wanted to say that I think my biggest concern is really that you can't replace all of the time it took to build the trust, the community, and the connection that the site made with the people using the site and with the community members at large. You can't just buy that back, and so closing it will cause indefinite harm. And so I think that's something that we just need to keep in mind, that we always think, oh, we can replace something or we'll have a better model, but I think it needs to be the yes and, because you cannot get rid of that connection. Like, you can't just buy back trust. So just wanted to put that out there. Thank you.
Councillor Leggett.
Thank you, Mr. Chair. I won't be supporting this motion, but I want to say that we really should be focusing on trying to get the provincial government to put more funds into the hubs than what they already have decided to put in. So we need increased funding for the treatments and for the staffing. And I think we can get them there, but as far as getting them to reverse the decision on the CTS, I think that's a no-go, and I don't think that's going to happen. So I think we need to turn around and switch our focus on the other. I attended the national summit over last week and over the weekend that the Canadian Centre on Substance Use and Addictions hosted. I was selected as a panelist to represent the reform, representing the mayors from across the country as to how this is affecting our communities. And I'll say what I said to them, that, you know, for those who know what a zeitgeist is, this is the zeitgeist of our time in history. Most zeitgeists have to do with a positive good thing, and how things like the Industrial Revolution or the Victorian Age, whatever, did good for that time in history. But ours is not going to be a good thing. Ours is going to be a negative unless we can pull out of this and look at the treatment end of this crisis. So we came together. Most of the people were harm reduction people. And so we talked about what the potential actions are that we can work on together to decrease substance use in a cooperative way. There was no them versus us. It was recognized that in addition to the human toll, that the crisis has also had a significant economic and social impact that requires effective responses. So I think that's what needs to happen. We need to get past this decision of the government to close down the CTSs and really focus on what they are offering us, because that's where the solution lies. It is all about upstream. And in Cambridge, we are focusing through the budgets about our youth. We're focusing on what we can do to make sure that there's not a next generation coming forward that's going to become part of the problem and have the problem in their lives that the current generation has. And I have great hope that with the hubs, that those that are suffering the despair of addiction, and that includes the families as well, who have also approached me recently from the survey that the City of Cambridge did. The families are supporting the request for some of the outcomes of that survey. But we have to get past this. We have to go forward and say, okay, what are the hubs going to offer? What do we want to see out of this? And focus on increasing the funds for that. I think that's important. I think the amount that's been given is not anywhere near enough. And saying, unless it's about $1 billion a year, we aren't going to get through this. Not in our lifetime. Thank you.
So we now, or no, excuse me, Councillor Foxton, this is your first time up.
Thank you, through you, Chair. I think our medical officer of health hit it on the head in that in a lot of things there are progressive stages, and the safe consumption site is the first step into the door, and the hard is the other part that will help people get through the other side and not have to use safe injection sites again. So I think what I would like to ask for is the partnership between the two, the same as our medical officer of health mentioned, that there is the need for both. And I think that we are not saying no to the new, but we're saying the ground starts with the safe injection sites. Thank you.
So I'd like to remind Council that we're now on our second round of questions. And we still have a fairly lengthy agenda to deal with in committee this afternoon and close. So just as a reminder, Councillor Deutschmann.
Thank you, Chair Erb. So just a couple of things. I just want to touch on one thing, for example, Councillor Craig's comments about the CTS and the effectiveness of, of outside of the CTS area. And I just want to remind everyone that when the CTS was established, the purpose of the CTS was to deal with what were deemed to be red zones in our community. So the CTS was addressing the red zone in downtown Kitchener and proposed to deal with the red zone, which was the second highest area in downtown Galt. So that's what the CTS was intended to do, and it's clear from what we heard from people today, it is effectively, very effectively fulfilling its purpose. So the issue outside of that area, I appreciate what Councillor Craig is saying, but that's not the CTS issue, fault, or what have you. So it is there for that purpose. And to use a roundabout analogy, yes, if a roundabout had a problem, we would go fix that roundabout. If a CTS has a problem, we'll fix the CTS. But the CTS is doing what it's intended to do, just like if a roundabout's doing what it's intended to do, we don't need to fix it. Just wanted to ask, we've mentioned UPHNS, and I just want to point out, we focused on the CTS closing, but Dr. Wong, how many UPHNS sites do we have in Waterloo Region? I believe One Roof, for example, is a site, and Bridges perhaps, but if you could just clarify.
There's 3 or 4. I'm not sure on the status of one of them, so that's why I'm saying 3 to 4.
Okay, so those sites are going to be closing as well under this legislation.
Under this legislation, they will be, if it passes as intended, they will be subject to the same restrictions as the current CTS sites.
Right.
Which are, do not, they cannot operate within 200 meters of a school or daycare.
Right, and presumably then, we don't have any stats or information, but those 3 or 4 sites are also reversing overdoses.
Yes, usually you situate, as you mentioned, exactly, sites like CTS or urgent public health needs sites where the needs are highest. And, like other communities, they often tend to be urban cores.
Yeah.
And therefore they're close or often close to schools and daycares.
Just to clarify, and I have a final comment, but just to clarify, is there one in Cambridge currently?
No.
Okay. So the final comment I just wanted to make is I hosted a drug strategy town hall with advocates from across the country and spoke with a number of other people, academics from across the country. Everyone supports treatment, but the view was prevention was that gateway to treatment. There were others that advocated forced treatment, like the proverbial or presumed Alberta model. But I just want to say this motion is advocating for prevention and treatment. This is bringing us and them, as Councillor Leggett referred to, together. This is not an us versus them motion. This is an us and them together. Prevention and treatment together, not just a focus on treatment, which some people are advocating. This is doing both together, and I appreciate the support of Council for this motion. Thank you.
Councillor Hunick.
Chair Erb, Dr. Wong, forgive me, I don't know who exactly to direct my question to, but there are lots of brains in the room, and I hope that someone can answer it for me. I am wondering, I care about CTS sites across the province. Dearly, I do, but I care most about those of Waterloo Region. And so I'm just wondering, would the motion that Councillor Deutschmann has put on the table have a greater impact for our community if it was specific to Waterloo Region rather than the province as a whole?
Do you want to respond to that, Councillor Deutschmann, in drafting, or, sorry,
Sure.
I don't want to interfere.
Sorry, go ahead.
Did you take that into consideration in drafting it?
I just wanted to comment on that, but if Dr. Wong wanted to say something, I can go after.
I don't think that making it Waterloo Region specific would make it stronger. I think it's fine.
Thank you, Dr. Wong. I just wanted to also reiterate the comments that I made with respect to the email that I received from Dane Kent from the Regent Park CTS, who specifically noted that this motion assisted them in bringing forward action by their Toronto Board of Health. How long that'll last for, I'm not sure with this legislation, but where they specifically said they wanted to fund their own site and break away from the province. But
thank you.
Yeah, thank you.
Councillor Craig.
Well, thank you, Mr. Chair. Again, coming back, and Councillor Deutschmann brought up the whole concept of we got a problem with the roundabout, you fix it. Got a problem with the CTS site, you fix it. Well, I can agree with that, but the problem we've had is we haven't looked outside the CTS site. And according to the health report that we had that was brought forward to us, We have over 10,000 people accessing harm reduction programs within the region of Waterloo. And some people claim, health experts, that it's as high as 30,000. And that's the issue that we're facing. And a CTS site, and I come back to it again, is seeing a very small, minimal group of people. I'm not suggesting they're doing anything wrong. I'm suggesting that our vision of the region has been limited by concentrating only on CTS sites. If anything, the new heart hubs will force us to look at the entire region, and I think that's very positive. The other aspect of all of this is the fact that one of the things we need is better data about what's going on. I am not faulting the health unit in the report they brought forward. They brought forth a report that had limitations because of staff, because of money and everything else. And we don't have enough data in terms of what's happening. And I think we need that kind of expansion as we go forward in the future. On a personal note, I said I was opposed to CTS sites. One of the problems I have is an ethics problem. And ethically, in terms of, do people that access CTS sites, do they understand the concept of informed consent? Are they able to understand what's happening? And I don't think they do. And I think it's an ethical issue for me personally, and one of the reasons I can't accept it. So my hope is, as we move forward, we look for more money for the heart hubs, and that we move forward in terms of looking upstream. I would like some further data, if possible, and how much longer we think this crisis of addiction is going to be in this region. Because I think we're looking at years into the future, which is most unfortunate. And we need to look at that in terms of revamping how we deal with upstream issues in terms of dissuading younger generations from getting involved in addiction issues. Thank you, Mr. Chair.
Councillor Vanovic? Okay. Councillor James?
Yes, through you, Chair Erb. I support this motion wholeheartedly. I am at a loss for just some of the ways in which the discussion is played out with the lack of human empathy right now. And, you know, this is another example of where governments are making decisions that are impacting people who are residents in communities without having informed discussions about the implications of these. And, you know, we don't know where this will go, but I think we have a duty to advocate for people who are part of this region who, you know, we don't know circumstances, but I think we can't lose sight of this human element. And I can, you know, Councillor Craig, listening to you speak about, you know, you don't support the CTS, you want all the data, and you know what, there are human beings, there are lives being lost that will continue to get lost. And regardless of the numbers, there are people here who are there's intervention happening. There is help where we are about to go into a process with a lot of unknowns because discussions haven't happened with the necessary people who are working on the ground. So anything we can do right now to ensure that there is something, or at least advocate, because there are people who are dying and going to continue to die, sadly, without anything. And, you know, anywhere you go in this world, anywhere I've traveled, we know that there's an opioid crisis. We know that there's a homeless crisis. We know that there's a hunger crisis, and there is little to nothing being done. And what we're seeing now is directly impacting people who are freaking out about the future. So, you know, Councillor Craig, I know that there's hesitation within communities around CTS's sites. But we have to do something, because clearly there's been decisions made where the implications have not been thoroughly thought out, and our staff are doing what they can to try and address the heart hub and get in there. All these unknowns. There's a lack of human empathy right now, and it's disheartening to hear as people who are making decisions about residents in this region and support that's needed. So I'll stop, but I want to call the vote right now.
Well, Councillor Sallin is online now and would like to speak to it. Go ahead.
Thank you. I actually just wanted to make a comment on Councillor James' comment. I find it unsettling that you would consider that council is not considering our residents in this discussion. I think that this is a topic that, yes, does impact everyone in our community, and many of which are some of our most vulnerable. Just because some of our councillors around this table have different opinions on how we best help and address this matter, I don't think means that we're lacking empathy. So I really just wanted to more so acknowledge a soft point of privilege, essentially, towards that comment. Thanks.
I just want to respond. My comment is not necessarily around this table because we are having a fulsome discussion. It is about decisions that are made above us that really there's been no informed discussion that's happening, where it's evident to me that there is a lack of empathy in how those decisions are being made because, as Dr. Wang said, there was no consultation about the Heart Hub. I know speaking with some of the service providers, there was no consultation or awareness. That to me is a huge problem. So, you know, to my colleagues, it's not a direction at you. It's a direction at what we're having to deal with as a result of decisions being made. So just to clarify, and again, I'd like to call the vote.
I appreciate the clarification.
We are going to vote, excuse me, on the motion. Before that, I would ask that if I may make a comment or two. I'm supporting this motion that's been brought forth by Councillor Deutschmann and seconded by Councillor Wolf. I'm thankful that they did it. I think it's unfortunate that the province painted all of the CTS sites with the same brush. Some of us were around and worked with the community when the site was established, and the collaborative effort and the hard discussions that took place to make this happen. And it was truly a collaboration of the community that put it together. And because of that collaboration, it's been successful. And it's so unfortunate that that success is being made with this kind of a decision. And I'm sorry that has happened. To the people that have worked day and night through unbelievable circumstances in what I would consider heroic fashion to save lives is just, we can't thank them enough. And to me, it's not a numbers game. It doesn't matter, or it does matter that lives have been saved, but if it's only been one, in my mind, it's worth it. And we need to acknowledge that all lives are important, regardless of what the numbers are. I think that the province threw out a number of something like 350 million it's going to cost to establish these new hubs. My guess is that they're going to spend that money and probably more, but they're also going to spend an equal amount of that money in extra emergency services that in the municipalities, in policing, in emergency services, in the EMS, that what they think they're going to put into the hubs, we're going to double in terms of responding to the needs in the community because the CST sites are not there. And I think that's unfortunate. The bottom line for me is the continuing stigmatization that we give to people who are some of the most vulnerable in our community. We're not seeing this as a healthcare issue, which it is, and we're removing something from the community, from the people in the community who need this, who necessarily don't have a strong voice for themselves and have to be represented by others. And I think that's so unfortunate. And I can't imagine the same thing happening. Like, what would the outcry be if we closed a dialysis unit or a diabetic unit, which is also a healthcare system, an important part of the healthcare system. And here we're closing something that is equally important to the healthcare system, and we're not having any success. And just finally, for the benefit of staff, I know how hard Dr. Wong's staff and how hard Commissioner Sweeney's staff has been working. This is such a full department of work that we're trying to serve the most vulnerable, and all of a sudden, the province comes along with something like this, and we need to respond to it. And all of the other things that we've tried to make priorities for, like a plan to end chronic homeless and all sorts of other things, get put on the back burner. And we wonder why we're not getting ahead of it. Well, this is a prime example. And so, sorry, thank you for allowing me to speak. The motion is on the floor.
Split the motion, please, the two resolutions.
It's only one resolution. It's a resolution asking for continued support for the consumption and treatment sites. It supports the heart. There's no support for heart hub systems. It's built into the resolution already. So it's not a split. It's either you support the continuation of the funding of the consumption and treatment sites in the UPHNS, or you do not.
The question's been called as well.
Yeah. So would you please use your e-scribe buttons to indicate your support? Councillor James, okay, coming. Okay, that is carried. Okay. Thank you for all who have attended, for delegating, for your patience, and for the work that you're doing, and hopefully in some way we'll be able to continue to do in the community. Thank you. So, Councillor Harris had challenged me to end the meeting as fast as his did, and so I think we've lost that one. So we're on to 7.1, strategic priority, equitable services and opportunities, and a response to time performance and call on Director and Chief of Paramedic Services, Mr. Richards. Welcome.
Thank you, Mr. Chair. And if the presentation could be brought up, that'd be great. Thank you. Committee, I'm before you today, and thank you for having me. If you remember, a year ago, we were here with this report for last year, and this is our mid-year performance report, which is part of your consent agenda, and hopefully you've had a chance to read it. I'll go over some performance highlights that we think are important to share with all of you. And then I also have a report on our 2025 response time performance plan, which asks for council's, a recommendation to council that we adjust our deployment plan, our response time targets, to be better in line with our key priorities and also our comparators across the province. Next slide, please. So this is just a quick brief slide about where we are for our KPI results for the first 6 months of this year. We have seen an increase in vehicle responses compared to the same period last year. I will remind council that in 2022, we had over an 11% increase in vehicle responses overall for the year. In 2023, that only increased by 1%, but we are now seeing a steady increase again, well above the 1%, but thankfully below the 11% threshold. Some good news. Our unit utilization is decreasing. The investments made by council and paramedic services is showing a decrease in our unit utilization, which I'll get to in another slide. Our response times have improved relative to the same period in 2023. We have struggled with offload delays in the first 6 months. That is particularly due to the month of January, which I'll get into in a little bit. And we have seen significant improvement May to June, and I'm happy to report that that improvement has continued through July until now. Code yellows and reds have decreased in frequency and total duration, although the median length of time we were in a code red and yellow has increased. And there's a number of different factors for that. Next slide, please. In terms of vehicle responses and utilization, we are, for the first half of this year compared to the first half of last year, we've seen almost 2,000 more vehicle responses. And we continue to be in a high growth scenario with a projection showing that if nothing changes, we'll see over 87,500 calls by the 2026 year, which is fairly significant and does inform our planning for both our master plan and enhancements as we move forward. In terms of unit utilization, a significant improvement in unit utilization compared to last year, 47, almost 48% for the first 6 months of 2023, and we're down to under 42% now for the first 6 months of 2024. And if I may, I remember Councillor Shantz asking me a question last year about when are we going to start to see things turn, and I'm hopefully telling you today that we're starting to see things turn in that regard. Next slide, please. In terms of response times, we have seen an improvement in response times of 6 seconds over the same period. That is a typo on your slide there. That should be 2024 reads 9:14 and 2023 reads 9:08. So I apologize that I didn't catch that before that went public. We have seen improvement in response times across 5 of the 7 municipalities, which is also significant. And we are seeing that response times, as I've always reported to council, are significantly impacted by things like offload delays and resource availability and those types of issues. As our units are in hospitals on offload delay, it means, generally speaking, they have longer to travel to respond to calls in outlying communities. Next slide, please. In terms of offload delays, as I mentioned earlier, we saw a real significant challenge in January. So that challenge in January has resulted in a worsening of offload delays for the first 6 months of this year compared to last year. But if you take January out, we see an improvement. And the equivalent right now for the first 6 months is that's the equivalent of losing 4 12-hour ambulance shifts per day, which is significant. That's 4 ambulances unable to respond to calls. January 2024 was the worst month on record for this service. We had 97 ambulance days lost in that month alone. And if you remember, I did communicate via email to council about what we were dealing with in January with that regard. I am happy to report, however, that we've seen significant improvement since January. From January to March, at the 90th percentile, we were at 125 minutes with respect to the ambulance offload time. From April to June, that is 90 minutes. And we are on track to, I'll just get my note here, in this current quarter, assuming everything remains the same, that'll drop down to 74 minutes for the current quarter. So we're really happy with that trend. It's important to me always to highlight our partners that are doing really, really well, and I'd like to acknowledge St. Mary's General Hospital for their leadership in dealing with offload delays for us. They, since July 1st, their 90th percentile offload time is 46 minutes, and the last week, their 90th percentile offload time is 31 minutes. Now, I'll remind council that the provincially accepted ambulance offload time is 30 minutes. So St. Mary's is hitting their targets, and the other hospitals are following suit, although have different system pressures as well. Next slide, please. With respect to code red and yellows, we have seen the number of events decrease across both code reds and yellows, which is good. The total number of hours decrease, and the percentage of time we're in code red or yellow also decrease, which is also significant, and to me is an indication that the improvements and enhancements that council has approved in our system are working. Although I did mention the mean has gone up. Next slide, please. We are always working on mitigation strategies to address all these system pressures, and all of these mitigation strategies apply to all of what I just reported to you with respect to the data. I would also like to point out our amazing epidemiology and health analytics team who deliver us such robust data that it allows us to make really good real-time decisions and future planning decisions for paramedic services. And to be honest, we could not make some of the decisions we make without the support of that unit. In any case, we continue to work with our hospital partners to address system pressures that cause offload delays. We continue to work with those partners to utilize provincial funding for the designated offload nurse program, and all hospitals will continue to see funding 7 days per week, 24 hours a day. We continue our goal to expand the patient care model standards, which will give our paramedics additional options such as treat and release, treat and refer, which means those patients that we respond to don't go to a hospital at all. We take care of them at the scene, and we refer them either to another healthcare professional and or we can discharge them from the scene. Or hopefully we'll get into the alternative destination space with the Integrated Crisis Center that you've already heard about and other options. And then as well, we also work within these model standards for things like paramedics providing palliative care to registered palliative care patients, and also hopefully an implementation of transport to hospice shortly. We prepare for the implementation of MPDS at the Cambridge CAC, which I have reported to you previously, and I'm pleased to report that we we believe and continue to advocate at the provincial level for a sped-up timeline for MPDS. Right now, we are on track to receive MPDS at RCAC in the first quarter of 2026. The council-approved Paramedic Services Master Plan shift to the high-growth scenario is probably the single biggest mitigation strategy that I can think of, because you need the resources in order to manage your response times and manage your call volumes. And then the final thing, which is also very important, is the further advancement of our community paramedicine program to address high utilization 911 users. We know that there are a variety of people in vulnerable populations who use 911 on a fairly frequent basis. And if we can address upstream solutions, which is what the community paramedicine program is designed to do, then that means the intended consequence we want is that they don't need to call 911. Next slide, please. I do wish to announce to Council that effective November 1st, we will be removing the terminology Code Red and Code Yellow. There's a number of reasons for this. I have reported on this in the past, but I'll just give you quick background. The current names and definitions have been in effect for almost 20 years and has never been adjusted in proportion to the number of resources deployed, so we need to change that model. The current definitions and criteria are: a Code Red is 0 ambulances available, and a Code Yellow is 3 ambulances available or less. One of the challenges for us operationally, and we've taken the last year to really identify the data and see where it takes us, but one of the challenges for that operationally is when we get into Code Yellow and we get notified by our CAC partner, oh, you're in Code Yellow, by the time one of us picks up the phone to call a hospital and say, hey, I need you to release ambulances, we're in Code Red. It's that quick, because 3 911 calls can come in 3 or 4 minutes. So we're changing our approach. The other reason we need to change our approach is when MPDS comes to the Cambridge CAC, that dispatch priority system will be dispatching paramedics on a color-coded system. And it will go from Code Green to Code Yellow to Code Orange to Code Red to Code Purple being your highest acuity or highest priority patient. So it's going to be confusing if we keep Code Red and Code Yellow to identify our system status and say, okay, we're in Code Red, but you're on a Code Red. Oh, wait, you're on a Code Yellow. It's just going to be confusing for everybody. So we're changing the names and the terminology, and you'll see them on the next slide, and they are part of the council report. Next slide, please. Thank you. So we're going to call Code Reds what they are, Code Zeros. So Code Zero will mean no ambulances are available. Code Critical will be 5 ambulances available or less at any time of the day, regardless of the number of units deployed. One of the things that separation between 5 and 0 will give us is allow us to build our mitigation and escalation pathways with our hospital partners and with our other system partners to try and prevent us from getting to Code 0 to begin with, which is the goal here. And then for code capacity, we're going to have 2 thresholds, one from 0800 to 2000, which will be 12 ambulances available or less. And to give you context, right now, in those times at peak deployment, we're at 36 units. So assuming nobody's on a call, we should have 36 units in the system. But because people are on calls, because people are on offload delay, because there are other, staff can get hurt, there's other reasons they can't respond, this is why we need that threshold. And then overnight, we're going to make that threshold 7 ambulances available or less, and that is simply because overnight we deploy less resources. So we wanted to make it proportion to the number of resources we deployed. For code capacity, that will indicate low to medium risk to the system as resource availability is reduced, but system is managing effectively, allows for escalation protocols to be implemented to help prevent entering code critical status. The other thing I'll advise council is that in the coming years, as we change our deployment matrix, as we increase resources, we will change these thresholds accordingly so that we're always in a kind of a real-time state of where the system can be. With respect, next slide, please, sorry. With respect to the response time performance plan and our recommendation before committee today, we are meeting the Ministry of Health compliance targets for 2024. Results from January to June 2024 are showing a slight improvement, and is comparable to the same period in 2023. And despite all these system pressures, I believe we continue to provide excellence in patient care and respond as quickly as possible. And we'll break into the different response time performance targets, please. Next slide, thank you. For CTAS and sudden cardiac arrest, this region, we have set a target. So the Ministry of Health sets a target that 50% of the time, a defibrillator must arrive on scene within 6 minutes or less. For the local area municipalities, this is where we work with the local fire departments for tiered response, and their data is included in our data and is part of that reporting. For the region of Waterloo, however, we increased the target to 70% because 50% was too low in our opinion, and we've hit it 70%. So we are meeting the Ministry of Health target, and we have seen a worsening of performance with respect to this metric specifically, but it is still well within the ministry target and a little bit below the region's target. I'm not afraid of that because to me that gives us a target to work for and achieve towards in terms of our deployment plan and adjusting things. With respect to CTAS 1 through 5, next slide please. I will remind council that CTAS 1 are your highest acuity patients that are not in cardiac arrest, and CTAS 5 are your lowest acuity patients, and arguably in some cases should be accessing healthcare through a different means other than calling 911. But you can see the percentages there on the slide. It does demonstrate that we are meeting, equaling what we did last year in the first 6 months of the year, or bettering it or improving on it. This is the question or the recommendation that we have before you today. We believe that it is time to change our response time performance plan to better reflect what our response priorities are, what the needs of the community are, and better make it easier for us to compare against our comparator services. So by changing the response time performance plan, it does get us updated to the 2024 kind of currently accepted standard. Our response time performance plan has not been adjusted in well over 10 years. So it, despite all the system enhancements we've done in those 10 years. So it'll assure that the goal is to ensure that our highest acuity patients are prioritized in system planning and operations, employ best practices that are comparable to similar paramedic services, help manage our staff workload so we can reduce things like end of shift overtime and missed meal breaks, and prepare for, again, the implementation of the medical priority dispatching system at the Cambridge CAC. The other goal here is to realign community expectations of response times to be more reflectively of the severity or acuity of the call. And if I could comment on that really quickly, right now we go out on what's called a code 4 lights and sirens, whether you're having a heart attack or whether you've sprained your ankle. And the expectations of the public is the same for both. And our goal is to make it so that we are responding to the heart attacks as quickly as possible. And that may mean that the sprained ankles need to wait in order for us to do that, which I think is a common sense approach to deploying our resources. In terms of, next slide please, in terms of comparison of response time performance plan targets, our service to others, the left column or the middle column is our current time response time targets, and the right column is the other services targets. And you can see that the other services, and I've listed them below so you know who we compared against, but if you look at those other services, they are all the suburban, urban, rural mix, except for Toronto, but the rest are all suburban or urban, rural mix like we are. And they've all for years had response time targets that are that you see increase as the severity of the patient decreases, which again makes sense. Next slide, please. So our recommendation is on the slide before you. It's also in the council report. We are not recommending that we change the compliance targets. We think that those compliance targets are reasonable and give us something to shoot for. But we are recommending that we change the response times, particularly for CTAS 3, 4s, and 5s, so that we can better adjust our deployment plan to focus on our sudden cardiac arrest CTAS 1s and CTAS 2s. And that is it. I tried to do that as quickly as possible, Mr. Chair, knowing where you're at with timing.
Thank you. We do have a number of questions, and I just want to remind my colleagues that we are behind schedule. This, however, is an important topic for the community, and if we can maybe keep it to questions and minimal editorializing. Councillor Foxton, set us off on a good example.
Thank you, Councillor Chair. I'll talk real fast. Excellent report. Good job. One question. In several cases, you mentioned 5 out of 7 improved. Who are the 2 that didn't?
I don't have that data specifically in front of me, but I am happy to. I am working with the EHA team to develop local area municipality reports that we can share at a future date.
Thank you.
Yeah, no problem.
Did I do okay?
You did great. Councillor McCabe, let's see you follow that.
Thank you. I don't promise to ever be as good as Councillor Foxton, but I'll do my best. Just wondered if you could, just thinking about the response times in that and what you mentioned the alternative destination clinic, and wondered if you could give us a bit of an update on that and when that may come on stream, because I see that, and based on what you've told us in the past, as a real opportunity to, excuse me, help with the offload delays.
Yeah, through you, Mr. Chair, and thank you for the question, Councillor McCabe. Paramedic Services is really involved with the planning and the support of the current Integrated Crisis Center, as Council knows, that opened, I believe, at the end of July. The plan, of course, is once that crisis center hits an operational state that they can begin to accept paramedic patients on, we would love on a 24/7 basis, but even on a 12-hour basis, 7 days a week, then we will apply to the province under the patient care model standards for alternate destination approval. That is a requirement under the Emergency Health Services branch, unfortunately. They can't just say, okay, the lights are on, you can come now. We have to apply to the province for that approval. Every indication, and we already have a draft approval proposal for the province, but we're waiting for certain thresholds to be met by the Integrated Crisis Center. And once that happens, we'll submit our proposal and hope that the province can turn around approvals very, very quickly. It would be hard for me to guess when that might be, but certainly our goal is 2025 implementation.
Okay, thank you for that. That's really helpful. And then my other question is about the medical priority, excuse me, dispatching system versus common dispatch. Like, how would those two things integrate, or would they? And I'm just wondering how that, like a common dispatch of fire, police, ambulance, how or if that would actually potential to reduce response times as well.
Thank you for your question, and through you, Mr. Chair. That's kind of a two-parter. With respect to the medical priority dispatching, that is the dispatch software and algorithm that all the CACs across the province will use once it's implemented at their location. And that will be required for specifically the call prioritization of 911 calls that need paramedic services response. So that will happen no matter what and needs to happen no matter what. With respect to the topic of a common dispatch, I believe years ago, and I don't remember the year because I wasn't here, but the idea of the region having one common dispatch for police, fire, and paramedics was advocated for and discussed back then. There is certainly operational value in a common integrated dispatch center in which there is one set of call takers and then you have a dispatcher for each emergency service. The areas that do that across the world do see some efficiencies in terms of call processing times and things like that. The other thing you see is real operational efficiency when it comes time to managing large-scale mass casualty incidents or things like that, as well as special event planning, which I know is near and dear to Council's heart here in terms of homecoming and St. Patrick's Day and things like that. That's where we're at with that. The legislative authority to run the CAC centers rests with the province. So they own and operate the CACs. They fund the CACs completely 100%. It is not funded through regional tax levy. And so, that's probably a larger debate or discussion about a unified common dispatch. Certainly something as a chief, though, that I would support.
Thank you very much. Really appreciate it.
Thank you.
Councillor Hudak.
Thank you, Chair Erb, and thank you, Chief Riches, for this excellent report, and particularly your strategic planning for those of us in our community who need paramedics. And so I'm really happy to see that the amount of offload delays is going down. I know ultimately that's more comfortable for the paramedics, more comfortable for those who use services, and saves the taxpayer money. I'm just wondering if you can speak to the cost of offload delays. Is that something that the province pays for because it is a healthcare expense? And if not, what is the shortfall? And is that included in our calculation of $280 million of subsidy on behalf of the province?
Thank you for your question, Councillor Hunick, and through you, Mr. Chair. I know you are. So I'll remind Council that through the Land Ambulance Service Grant, 50% of the cost for paramedic services in the region are covered by the province. So anytime we, I would say, we incur operational costs for paramedics waiting in the hospital, and that the province is paying 50% of that. I would argue, make that argument. The other thing is the province is funding our designated offload nurse program at 100%. And we do see that the results of that program are being very effective. As I already reported earlier, we are seeing improvement across all 3 hospitals. And we know that that's because of the designated offload nurse program. So they're funding 100% of that. With respect to the true cost of offload delays specifically, the reality is, as we build our deployment plan and our needs for paramedic resources based on population growth and other metrics, certainly offload delays create a system pressure for us. We know that they're there, but we're trying to build our system assuming that offload delays don't ever exist, because I personally don't believe council should be funding paramedics because we have offload delays. That's a conversation for the province, I would argue. But there is a real cost to offload delays when you lose, hundreds of hours, if not thousands of hours a year, to paramedics being stuck in hospital, and more importantly, their patients being stuck on uncomfortable paramedic stretchers waiting for healthcare. Those are all resources that cannot respond to 911 calls. And so, despite our challenges with offload delays, we've seen our unit utilization drop now down to just under 42%. If we had no offload delays, we would probably be hitting our 35% unit utilization target. So it's kind of a push-pull, if that makes any sense to you, Councillor Hunick. But I'm happy to answer any other questions about that. Thank you.
Thank you for that thorough answer. It does make sense to me because I have way too much experience with the healthcare system. But do we know if that cost of offload delays is calculated within our subsidy of provincial services, being the 280 million, or is that over on top of that? Sorry, 180.
So I think we're funded a little differently, if I may, than other regional services. So we are funded under the Land Ambulance Service Grant, which means that at every summer our financial team has to submit our costs for the previous year, and then we receive a Land Ambulance Service Grant funding letter that says, here's how much we're covering. It is at the 50% mark, which is obviously was the province's commitment. I don't know that I don't think offload delays and the cost of offload delays contributed or are considered in other areas, although I may be wrong about that.
Okay, thank you. I'm happy to move this report as well.
Thank you.
Thank you.
Okay, we'll put that on the back burner for a minute. We have 3 or 4 more speakers, and then we'll come back to that. Councillor Hunick. Councillor Craig.
Thank you, Mr. Chair. Through you. Sir, you made the comment that 5 out of 7 municipalities you understood the delays that were taking place, or the time periods of response, but you can't name the other 2 municipalities. I don't understand that.
I just don't have those with me today, Councillor Craig. I was expecting a question from you about response times. Yeah. So I do have information for Cambridge today.
Well, yeah, and I'll be looking for it. I'm very interested, of course.
Yeah.
Because in Cambridge, this has been going on for years, the delays in terms of beyond what other municipalities are receiving. Okay, thank you.
Thank you.
Dr. Wong.
I just wanted to provide some additional information that response times based on municipal geographies will never be equal to each other. That's because response times are a function of the density of the population where the calls occur, as well as the geographical distance that this population is spread out over. So a municipality where there are a lot of people that are in a particular area and the calls are coming from that densely populated area will have shorter response times on average than a municipality where there's less people and they're more broadly spread out through that geography. So while there are things like increasing resources that we can do to reduce response times overall, there will always be inherently differences in response times based on the, the boundaries that have been created for area municipalities, just because of their, because of the characteristics of their population, that is the density and the geographical distance where they're spread out. So just wanted to provide that additional information. Hopefully that helps.
Mr. Chair, if I may. So what we're saying is, because of the slower response times in Cambridge, it's because of density and geographical limitations. Is that what you're saying?
I'm saying yes, that's always going to be a factor when you look at response times for municipalities. So you can't, it's apples to oranges if you're comparing a municipality where the population is very densely populated versus another municipality where the population is more spread out. And if Chief Riches would like to add anything to that, I'd welcome that. But I know the comparisons for municipalities are something that we continue to monitor and look at, and obviously we want to reduce response times for all our area municipalities across the region. So that's something we look at when we look at the planning for the services, the deployment. But there will always be that factor that makes it such that you can't say that our goal is to have the same response times between municipalities, because physically there's going to be differences based on density and geography that the service will have to cover.
Okay, thank you, Mr. Chair.
If I may, the other challenge that we see, and especially in the townships, is the frequency of calls, because you have less calls. For example, and I'm just picking an example, if in a township you have 4 CTAS 1 calls, and 3 of them meet the response time criteria, but 1 doesn't, that 1 will make it look like none of them have met for the year, because there's only 4 CTAS 1 calls. Whereas in Kitchener, Waterloo, or Cambridge, the sheer volume of calls, 1 call as an outlier would not suddenly change the response time metrics for that municipality, if that makes any sense.
Councillor Foxton is asked to.
Yeah, very quickly. It's not an attack on you. I know that we're further out.
Yep.
And I know road construction is hell. Took me an hour to get here today, whereas usually takes me 25 minutes. Thank God I wasn't an ambulance. But I recognize the differences, and I think we do, and it's not a slam against you. Yep. It's the reality of we choose where we live, and we choose what comes along with where we live. Thank you.
Thank you. Appreciate the clarification.
Councillor Deutschmann.
Thank you, Chair Erb. So it's Acting Commissioner Spooner's fault. So just so we're clear. Chief, I appreciate your comments, but I think knowing the question that's going to be asked, one might expect that some information on maybe the trends in Cambridge, for example, would be respectfully presented today.
As I mentioned, I do have the trends in Cambridge.
Okay, so why don't you provide that information? Because I don't think Councillor Craig realized that you had mentioned that you had something, and I kind of caught that, so go ahead.
Thank you. Appreciate that, and appreciate the opportunity, and through you, Mr. Chair. So for Cambridge specifically, overall, the 80th percentile response time have improved from 2015 to 2023. 2021, there was a low of 8 minutes and 41 seconds for the 80th percentile. It did then increase up to 909 in 2023, but it is now down to 904 in 2024. And when you compare Cambridge for the first 6 months of this year to the first 6 months of last year, there's a 19-second improvement on response times. So we are seeing improvement in that municipality specifically, and I do apologize to council. I probably should have prepared one for every single municipality, but I was anticipating Councillor Craig's question, which is why I brought that data. Thank you.
Just a follow-up, Chair. So thank you for that, Chief. My question originally was just with respect to, we had a big discussion about the Heart Hub, and I thought in my research I might have read that there was an opportunity for paramedics to Is there an opportunity to offload certain patients to the Heart Hub versus the hospital emergency department?
Through you, Mr. Chair, and appreciate the question. Let me start by saying that Paramedic Services is involved with public health and our system partners in supporting the Heart Hub application with our data, because obviously our data is a real barometer of where we're at in terms of what's needed for that community. It's not clear to me at this time whether the Heart Hub will be an eligible alternative destination, although I certainly think it's a question that should inform our planning, and that as you've already heard the timelines, they're very tight in terms of submitting the approval request, that if the Heart Hub met certain criteria, I could see the Emergency Health Services branch accepting our request to transport there. But similar to the Integrated Crisis Center, we need it to get to a certain operational state before we can do that. Yeah.
Chair Redden.
Thank you, Chair Erb, and I really want to thank you, Chief, for a very informative report. I've always observed that governments measure what they value and change what they measure, so I really do appreciate the data. Trends seem to be going in a good direction, and this council, as previous councils, have really invested and supported paramedics. It's something that I think the whole community relies on. So I've got two questions, if I could. As we recognize we grow to 1 million people in, by 2050, is there a growth factor that is figured into any of the funding requests or the funding we get from the province? And you've talked about alternative destinations and offload nurses, so clearly we're being innovative. And can you talk just a little bit about the input you've had to the future hospital and how that may continue to impact these stats that we're talking about?
Thank you, and through you, Mr. Chair. With respect to the growth factor in terms of application for funding, we are in the process of revamping our master plan, and I expect to bring to council next year a revamped master plan that makes us look out from 2025 to 2035. The current master plan we're on technically ends in 2027, so we're trying to get ahead of it. And in that master plan, things like population growth and density, urban density, where the calls historically have been and where we will continue to see them, and things like the location of health system partners, locations that we can transport to, all those things are factored in. With respect to how we attach that to funding requests, that's a question I probably need to think a bit more, because as I've already mentioned, the Land Ambulance Service grant process is basically how much did you spend last year? You submit the budget you spent, and then they cut you a funding for 50% of that. So really what our focus and my focus will be with the team will be to present to council a really robust plan for reasonable and sustainable growth of the paramedic service that council can approve, knowing that the province will cover 50% of the bill, so to speak, if that makes any sense. With respect to the new hospital, we were informed, as were other partners within the region, about the location. We were asked for our data early on before they decided on the final location. The final location for the new hospital is obviously in an area that is kind of north of the urban core currently, and that does cause us to think about how we're going to deploy our resources once that hospital comes online. But one of the things that the hospital planning consultant has told me is that their plan is to keep Grand River Hospital open as an emergency department for at least the first 2 to 3 years of that transition. If council might remember, a year ago when they talked about this, the plan was close St. Mary's, close Grand River, open up the new hospital, and we would end up with 2 emergency departments with respect to paramedic services. That does not appear to be the plan now. It'll be a new emerge up in the new hospital, Cambridge Memorial, and then Grand River, at least for the first 2 to 3 years, which will at least help us transition to this change in hospital location. The other thing about the change in hospital location is where they're going to put certain services, because currently through our deployment and our transports, certain specialty services get transported to specific hospitals. So for example, for those suffering a heart attack, we transport them to St. Mary's. For those suffering a stroke, we transport them to Grand River. And so when the new hospital comes online, where the specialty of services will be obviously a huge data point for us to adjust our deployment plan. And then finally, I'll also say one of the things that I know is in the plan for the hospital is a helipad, which is a big positive deal for us, if I could put it that way, because currently our resources have to go to the Regional Waterloo Airport to pick up the helicopter crew and then transport them to an emerge and then take them back, which takes a lot of time and it is arguably not operationally efficient. So with a helipad being at the new hospital, that will reduce the demand on our services when Orange comes in to pick up a critically acute patient, which is helpful.
And if I could just make an observation, Chair Erb, I really want to underscore that this is a systems approach to paramedics to healthcare. Cambridge is a huge piece of this, as much as people are focusing on this new location of a hospital. So thank you very much for continuing to do that systems approach. I think it's really important that all areas of the region be serviced.
Thank you. Appreciate that.
Dr. Wong wants to add a comment here.
Just a quick comment in support of what Chief Richards said about the importance of master planning for the service. You know, as our population grows, we know we are going to continue to grow significantly. And the master planning that we have done to date has served us well, because through the plan, you know, we said we project that the calls will increase to, you know, to this extent or that extent because of the growth of the region. And even though at first, sometimes we look at that, we say, really? That's a lot. But the plan said, no, that's what we project is going to happen. And you're going to need these, you know, additional ambulances, et cetera, stations, et cetera, as a function of that. And to date, the plan has been
proven,
has been really good in that has really projected where we did end up. And so that's why, you know, and that's why we've been able to, you know, make requests of council that are really based on the best available evidence. And so our plan is to bring back an updated master plan, because we have to do that every several years. And I expect that will continue to help us be proactive about strategically planning for the future. Thank you.
If I may add, through you, Mr. Chair, the other reason for updating the plan right now is specific to Chair Redsman's question about the new hospital, is we know when the new hospital is coming online, and so we need to have a plan that incorporates the implementation of the new hospital. The current master plan does not contemplate a new hospital in our region, so that's another reason to update it as well.
Councillor Shantz.
Thank you, and thank you for improving the offload delays with the offload nurses. I think that's a good initiative. I recently heard another story that has me very concerned about timing, and that is I understand many of the doctors in the long-term care facilities have lost hospital privileges. And so this is a woman in a long-term care facility who needs a blood transfusion every 2-3 months because of her condition. And she gets transported by ambulance to emergency and has to wait. If a doctor has hospital privileges, they can book a time in the transfusion unit and reduce some of that time. So I guess I would, and maybe you can speak to that, but I would also encourage you to continue to work with the hospitals and the long-term care facilities and find a resolution to that, because that's silly. She was there. The ambulance would have been there probably 6-7 hours.
Through you, Mr. Chair, if I may, what you're getting into, Councillor Shantz, is like health system patient level planning, and that is very, very complex. And certainly in our world, we see the results of an overburdened healthcare system because the outcome is offload delays. Offload delays are not causing the challenge. The outcome is offload delays. With respect to long-term care homes, there is a lot of opportunity to work with long-term care homes so that they can receive, and I know many of them are already working on it, receive some of those types of treatments in place rather than being transported, I would argue is probably the first thing. And the province has funded 2 municipalities in the province to develop something called a community paramedicine long-term care plus model. The region of Durham is one, and I can't remember the other right now. And the concept of that is community paramedics providing some of those types of treatments for the patients in their long-term care home, so they don't need to be transported at all. And certainly when our community paramedicine program is ready to take on that additional work, it's something we'll be asking the province to fund us for, because we think it's really valuable and it demonstrates what paramedics can do to help the system. Thank you.
I'll just quickly add, in response to your specific query about, I think you mentioned physicians losing their hospital privileges. That is a health care system issue, but we can pass that feedback to our partners at Ontario, in the Ontario health teams. Thank you.
If I may, the physician privileges things at hospitals is it used to be very, very simple. You were a community doctor and you had privileges at your local hospital. That's the way it was. It is very complex who has privileges for what now. Some doctors may have privileges at 2 or 3 different hospitals. Other doctors elect not to have privileges at all at a hospital. It's very, very complex. And but certainly the feedback can be provided that if physician privileges are one of the challenges experienced by the person you talked about, then that's something we could share moving forward.
Thank you. I appreciate it. Politics doesn't just exist around this table, right?
Do you want to speak again? No. Okay, sorry.
Councillor Vanovic.
Thanks very much, Chair Erb, and thanks, Chief, for your presentation today and for the work that the women and men of EMS do each and every day. I guess a couple things. First of all, on the recommendations around the new response times, generally speaking, a number of the ones that you're proposing appear to be better than sort of what we're seeing with all the municipalities that you had in the report. But there were a couple that seemed to be a different priority or a different percentage than some of those municipalities have done. Is that primarily because we're focusing on the SCA CTAS 1 as our main area of focus? Because that's where maybe we'll have the greatest impact on, particularly from a saving of life point of view?
Yeah, and through you, Mr. Chair, thank you for your question, Councillor Verbanovic. Yeah, the goal here is to have a response time performance plan, which is a legislative requirement for the province. Like we're required to submit this by October 1st every year, which is why I'm here today. The goal is to have a plan that actually reflects the patients we're going to prioritize in our deployment. And so that's why you'll see those target times be much more narrow for sudden cardiac arrest and CTAS 1 and even CTAS 2, because those are sick patients as well. It's to take the CTAS 3, 4s, and 5s and say, okay, if we don't get there in 14 minutes, which is currently what we're trying to do, that's okay because we're going to save that resource for the CTAS 1 is essentially the common sense approach. Does that answer your question?
Yep. Okay. No, that's helpful. Thank you. The other thing is I was encouraged to hear about the thinking that's going in terms of the long-term planning and work on the new hospital and how that will work. Also in terms of some of the thinking around, because there is ongoing dialogue, as you're likely aware, around what the Grand River site in Central Kitchener will continue to do in terms of urgent care versus emergency, because there is some thinking that, in fact, as the community grows, we will need that emergency department as well. And that's certainly a position that the City of Kitchener has put forward in the work that we're doing with the hospitals on that, and believe that it will be important, partially because of some of the information that's out there in terms of where patients are coming from into emergency and so on, and making sure that we're serving those members of the community in the most effective way possible. So I'm glad you're on top of it and look forward to additional information in the future. Thank you.
Thank you.
So no more speakers. This report has been moved by Councillor Hunick. Did you want to second it, Councillor Vanovic? Sure. Okay, seconded by Councillor Vanovic. Could we please use our yes or no buttons to indicate our support? That is carried. Thank you. The next item is 7.1.2, Paramedic Services Key Performance Measurements. For information, my guess is that a lot of that was incorporated into our previous thing, and so we'll...
Fully incorporated, yeah.
Just take that for information. We've done 8.1, number 9, Council Committee tracking, and some communication from the Waterloo Regional Drug Action Team was submitted. Is there any other business? Councillor Craig.
Very quickly, Mr. Chair, and I don't know if this is possible, and it's a follow-up to our earlier discussion. Is it possible, this is to Dr. Wang, about to look at the next number of years in terms of the addiction issues and the prevalence of that, in terms of going into the next 5, 10, 20 years, what we might see? I don't know if you can answer that or someone can answer it, but my concern is, what I'm concerned about is this continuing cloud we're living under.
I think that's a very good question to ask, Councillor Craig. Thank you for that. I don't think anyone really can provide a valid estimate about how many people will be using in the coming years, how long this will last. But I do think that based on all the trends we've seen to date, what you said about many people remaining addicted and, our communities needing comprehensive solutions along the full spectrum from prevention all the way to the treatment is very likely to be what we see. So I don't think I'll be able to bring back to you an answer, because I don't think even those that treat people with addictions will be able to project. But I think that based on the trends that we've seen to date, we will continue to see several years, of this challenge of addiction and overdose. So I agree with what you said about the importance of making sure that the strategies that we employ cover the spectrum from prevention all the way to treatment.
Okay, thank you. Mr. Chair, just one other comment, if I may. It involves Mr. Sweeney. I called him, I emailed him on Friday with a particular issue, Friday afternoon, and usually difficult things always happen on a Friday afternoon, and it was involving a resident who had some particular issues with her unit, and Mr. Sweeney had it resolved, offered her a hotel for that night, a meal out, and someone to come in and fix the problems the next day. And I thought that was really a great response, and publicly it's a great response. I want to thank him publicly.
Mr.
Thank
Chair?
you. Thank you.
Mr. Chair?
Our Councillor Deutsch.
Yeah, in that same vein, I just wanted to mention that I had a call from a constituent who's concerned about an issue in downtown Kitchener, and I want to commend Councillor Vanovic, who went out on a Sunday to check out the situation. So I just want to commend him as well for putting in the time. Thank you.
Next meeting, October the 8th. Now we'll entertain a motion to go into closed session, moved by Councillor Foxton, seconded by Councillor Shantz, that a closed meeting, the Sustainability, Infrastructure and Development Administrative and Finance Committee be held on September the 10th, 2024, immediately following the Community Health Services Committee in accordance with Section 239 of the Municipal Act 2001 for the purposes of considering the following subject matters: advice that is subject to solicitor-client privilege for the purpose of litigation before an administrative tribunal, and personal matters about an identifiable individual. Could you please use your yes or no buttons to vote? Now, that's carried. Now I entertain a motion to adjourn this meeting. Moved by Councillor McCabe, seconded by Councillor Harris. Use your yes or no buttons to indicate your support. Okay, so this meeting is adjourned. However, I'm looking for guidance, like what are we going to do next? Are we going into closed? We had a little, okay, we're going into closed. Okay.